Good morning. This legislative hearing of the Subcommittee on Health will now come to order. I want to welcome all the members of the subcommittee and our witnesses for attending. Today we'll be discussing 10 bills that would address issues impacting our veterans and that direct VA to initiate fixes. These bills address issues raised in subcommittee oversight hearings to ensure veterans get timely access to substance use disorder treatment and to help ease VHA staffing shortages. They also enhance peer support networks, explore a new long-term care option, boost suicide prevention efforts, and even provide flood mitigation solutions. I'd like to take this time now to speak on my bill, H.R. 3520, the Veterans Care Improvement Act of 2023. For several years, committee staff and many of the VSOs with us here today have heard accounts of the VA's unsatisfactory compliance with Mission Act's community care guidelines. The partnering of VA care along with community assets has had a demonstrable impact on the quality of medical care made available to veterans across the country. My bill would continue to make VA healthcare system more accessible and accountable to those in need of its services. It would codify current access standards, setting a baseline expectation for timeliness of care. It would establish a defined access standard for the provision of residential substance use disorder treatment, recognizing that when a veteran decides that help is needed, time is of the essence. It requires VA to be more transparent with veterans when they are deciding their best options for care, whether in the VA or in the community. My bill also creates a pilot program through the Center for Innovation to incentivize how community providers interact with the VA, creating a more collaborative and value-based approach, and yes, working to improve several aspects of their performance as well. The effective partnering of the VA care with community care results in more quality care overall. Veterans should have full transparency into their eligibility, their options for care, reasons for denial, and avenues for appeals. Knowledge is power, especially when it comes to making decisions critical to your health. I'm grateful to our witnesses and those organizations that submitted statements for the record for their thoughtful feedback on my bill and the other bills on today's agenda. I look forward to learning more about each piece of legislation being considered today, their merits and their challenges, and the impact they could have on the VA operations, and most importantly, veterans' lives. Again, thank you all for being here. I now yield to Ranking Member Brownlee, who is also sponsoring H.R. 1278, the DRIVE Act, for her opening remarks.
Thank you, Chairwoman Miller-Meeks. Appreciate it, and appreciate you for convening today's hearing. I look forward to our discussions of the 10 bills on today's agenda, including my bill, H.R. 1278, the DRIVE Act. This legislation will increase the mileage reimbursement rate for VA's beneficiary travel program, which helps cover expenses for eligible veterans when they must travel to receive treatment for a service-connected condition. Specifically, my bill would make VA's rate 62.5 cents per mile, equal to the per mile reimbursement federal employees receive when driving personally owned vehicles for government business. VA's beneficiary travel reimbursement rate has not been increased since 2010, when it was set at 41 cents per mile. In the meantime, veterans' travel costs, including gasoline, vehicle maintenance, tolls, auto insurance, etc., have risen steadily. I'm pleased that VA and many of the organizations testifying or submitting statements for the record for today's hearing support my bill, which will help ensure veterans can travel to receive the care they need, whether it be at a VA facility or in the community. I'm also pleased that we are considering Representative Slotkin's bill, and I know she wanted to be here today, H.R. 1815, the Expanding Veterans Options for Long-Term Care Act. This bill would create a 3-year pilot program in 6 different locations where VA would assess the effectiveness of covering assisted living. Typically, assisted living is a less intensive and less costly care setting for individuals who may otherwise end up admitted to nursing homes. Veterans' access to long-term care has been a long-standing interest of mine, and this legislation would explore the feasibility and potential cost-effectiveness of broadening options for veterans. I understand Representative Susie Lee will be here today to speak in support of her bill, H.R. 1639, the VA Zero Suicide Demonstration Project Act. I will defer to her to tell the subcommittee more about it, but I wanted to express my support. And turning to the other bills on today's agenda, I expect more robust discussions of many of the bills, and almost all of them I am completely in support of. I do have, some concerns over the chairwoman's bill, H.R. 3520, the Veterans Care Improvement Act of 2025. So first and foremost, in terms of concerns, I'm concerned that the bill will lead to a far greater utilization of community care among veterans, driving them outside of VA's direct care system, where they will receive more costly, less timely, and oftentimes lower quality of care that they would otherwise receive at VA medical centers. Just last week, a national survey published by the Centers for Medicare and Medicaid Services found that veterans rated VA hospitals higher than private sector facilities in all 10 patient satisfaction categories. At the same time, research shows that access to care in the community, particularly in rural areas, is actually shrinking and patients' wait times are increasing. So I'm concerned that H.R. 3520 would expand veterans' eligibility for community care so that there would seldom be a situation where a veteran wouldn't be offered community care. For example, this bill would allow veterans to obtain community care referrals simply by expressing to the VA provider that it is their preference to be referred to the community for care. It would also bar VA from factoring in the availability of VA telehealth appointments when clinically appropriate when making community care eligibility determinations, understanding that we're not doing that now, but in the event that we can get to a place where we can refer to telehealth appointments, I think is important. We are, of course, still awaiting a CBO score for this legislation. However, if past experience is any indication, H.R. 3520 would drive up VA healthcare spending by tens of billions of dollars. Since implementing the Mission Act, more than a third of VA's clinical encounters are happening in the community. Taxpayer spending on community care has far outpaced increases in VA's direct care system. I'm concerned that this simply isn't sustainable in the long run. There is one very important area in which I hope we can work together to find some common ground. Under the chairwoman's bill, veterans needing residential substance use disorder treatments would become eligible for community care referrals when care at a VA facility is unavailable within 10 days of the veteran's request or within a 30-minute drive time of the veteran's home. Our subcommittee recently held a very good oversight hearing on this topic, and I was compelled by the testimony of many of the organizations that participated. I do think there are opportunities to clarify and streamline access standards for residential substance use disorder treatment. However, I think we need to think through what the drive time requirements should be. I want to work with the chairwoman to address this issue and to define access standards that we can all agree upon moving forward. I hope today's hearing will provide an opportunity for a robust discussion of this and other bills on today's agenda. And with that, Madam Chair, I will yield back.
Thank you, Representative Brownlee. We have a full agenda today, so I'll be holding everyone to 3 minutes per bill so that we can get through them in a timely manner. I'm honored to be joined this morning by one of our colleagues, and we also had colleagues who wanted to be here but unfortunately have been delayed. Representative Kiggins wanted to speak on H.R. 3581, the Caregiver Outreach and Program Enhancement, or COPE Act, and Representative Lee sponsoring H.R. 1639, the VA Zero Suicide Demonstration Project Act of 2023. Their work and dedication to helping our veterans is very much appreciated. I would now like to recognize Representative Jennifer Gonzalez Colon, you are now recognized for 3 minutes.
Thank you, Madam Chair. I'm so happy to be back in this new, committee room. I was part of this committee when I came to the House of Representatives in the 115th Congress. Chairwoman Miller Meeks and Ranking Member Brownlee, happy to be here with you. And thank you for the opportunity to testify on my bill, H.R. 1182, the Veterans Serving Veterans Act of 2023, and for including it in today's legislative hearing. Maintaining adequate staff levels is essential to the quality of services our veterans seek and deserve when in need to care from the Department of Veterans Affairs. We have a single medical center and a network of clinics serving our veterans communities residing in Puerto Rico and in the U.S. Virgin Islands. And each of these facilities are important, just as the staff who go to work every day and provide direct service to the veterans. And yet, like the rest of the country, we see the challenges with hiring and retaining our VA staff. H.R. 1182 seeks to support staffing levels at the VA by increasing the visibility of current vacancies and fostering the recruitment of former members of the military to fill these positions. The bill will authorize a single searchable database for recruitment within the VA. The platform will include the military occupational specialty or skill that corresponds to a vacant position, as well as each qualified member of the armed services who elects to be listed in the database and may be recruited to fill the position prior to being discharged and released from active duty. The Secretary may exercise expedited hiring, as well as authorize a relocation bonus to a member of the armed services who has accepted a position and requires this assistance. Lastly, this bill will establish the Intermediate Care Technician Training Program to train and certify veterans who serve as basic health care technician while in the armed forces to work as an intermediate care technician in the VA. I trust this bill could facilitate greater collaboration between the Department of Defense and the VA and will allow for veterans to use their skills and training to serve and work with other veterans. This bill is not the first time that it's been considered in the 115th Congress. It was passed unanimously by the committee as well as the House of Representatives. But you know what happened with our cousin in the Senate. So I look forward to receiving any feedback and welcome any suggestions from today's panel on ways that we can move forward with this legislation. Thank you, and I yield back.
Thank you, Representative Gonzalez Colon, for speaking and sponsoring H.R. 1182. As is our practice, we'll forego a round of questioning for the members. You are now excused. I'll now invite our second panel to the table. Thank you very much. Joining us today from the Department of Veterans Affairs is Dr. Erica Scavella, who is the Assistant Undersecretary for Health and Clinical Services in the Veterans Health Administration. Accompanying Dr. Scavella today are Dr. Colleen Richardson, Executive Director of the Caregiver Support Program, Dr. Scott Hartronf, Executive Director of the Office of Geriatrics and Extended Care, and Dr. Mark Hausman, Executive Director for Integrated Access in the Integrated Veterans Care Office. Dr. Scavella, you are now recognized for 5 minutes to present the department's testimony.
Thank you. Good morning, Chairwoman Miller-Meeks, Ranking Member Brownlee, and members of the subcommittee. VA apologizes for its written testimony being submitted late. Thank you for the opportunity to discuss the Department of Veterans Affairs' views on pending legislation regarding veterans' health care benefits. I am accompanied today by Dr. Colleen Richardson, the Executive Director, Caregiver Support Program, Dr. Scotty Hartronf, the Executive Director of the Office of Geriatrics and Extended Care, and Dr. Mark Hausman, Executive Director, Integrated Access. My opening remarks will focus on 3 bills. My written statement provides more detailed information on the stated bills on today's agenda. The first bill, H.R. 1815, Expanding Veterans' Options for Long-Term Care Act, would require VA, beginning not later than 1 year after the date of enactment, to carry out a 3-year pilot program to assess the effectiveness of providing assisted living services to eligible veterans and their satisfaction with the pilot program. VA could extend the duration of this pilot program for an additional 3 years if VA determined it appropriate to do so based on the results of the pilot, which will be provided through annual reports to Congress and reviewed by the Office of Inspector General. With amendments, VA supports this bill subject to the availability of appropriations. VA appreciates that the current version of this bill has addressed several technical concerns identified with similar legislation that has been proposed during the prior Congress. VA generally agrees that specific authority to furnish assisted living services, particularly through a pilot program to assess effectiveness and veteran satisfaction, would be helpful addition to VA's options for providing long-term care services to help veterans and their families. It will provide VA with increased options to appropriately serve veterans and their family members in the appropriate care setting for their specific needs. VA supports the protections this bill would include to ensure that veterans are receiving appropriate care for their needs. While VA appreciates and fully supports the intent of this bill, there are recommended amendments that have been described in my full written statement. I would direct the committee to my written statement regarding H.R. 3520, Veteran Care Improvement Act of 2023. VA is generally opposed to codification of access standards as it removes the ability of the Secretary to develop and publish such standards that provide veterans with options to access the right care at the right time based on their clinical needs. VA cannot support codification of residential treatment and rehabilitative services as proposed in this bill. While we generally support the establishing of a wait time standard of 10 or fewer days for the delivery of care, we have significant concerns with the 30-minute drive time standard for residential treatment program at this time is inconsistent with industry standards and the accessible care that is available and could result in significantly greater financial costs to VA without any guarantee that veterans will receive care that is closer to home. VA does not support specifically Section 2 of H.R. 3581, Caregiver Outreach and Program Enhancement Act, or the COPE Act, which would authorize VA to award grants to carry out, coordinate, improve, and otherwise enhance mental health counseling, treatment, and support to the family caregivers of veterans participating in the Program of Comprehensive Assistance for Family Caregivers, or PCAFC. VA acknowledges and is grateful for the incredible work and sacrifices of family caregivers and the sacrifices that they make to take care of their loved ones. We have recently begun using regional clinical resource hubs, which are staffed by VA specialists, that can provide direct mental health care to family caregivers using telehealth, which is an option for mental health support desired by the majority of the PCAFC caregiver respondents in previous surveys. We believe these efforts will best address the intended goal of this section, and we agree that support is needed. As utilization of these services through VHA clinical resource hubs increases, VA will continue to assess and identify opportunities to resource and improve supportive services and meet the needs of our family caregivers for veterans. This section of the bill as written will require significant complexities and create significant complexities to administer and manage these grants as it is currently written. This concludes my statement. We appreciate the committee's continued support of the programs that serve the nation's veterans and look forward to working together to further enhance the delivery of benefits and services to veterans and their families.
Thank you for your testimony, Dr. Scavella. I now yield myself 5 minutes. Dr. Scavella, yes or no, are veterans ever required to utilize community care should that care or service be available at a facility when distance or time across standards are not met?
Thank you for the question, Chairwoman Miller Meeks. Veterans are always given the choice of the care that they receive, and they have the opportunity to determine with informed decisions whether that care is received within the VA system or within the community. There is no requirement that they go to the community, just as if we can provide the care within VA, we would hope that they would choose to take whatever type of care is best for them, whether it's in our system or in the community.
So I'm just going to emphasize that. So should community care be available, it is not required even under this bill. It would not be required for a veteran, even if they met the requirements for community care, to obtain community care.
Correct.
So codified access standards would only maintain what is currently available as a veteran's option, not changing the requirements.
So our concerns with codifying this particular piece of this legislation we have concerns that in instances in rural America, it still may not allow them to receive care sooner. That is our concern with relations to that particular.
Well, certainly, if there's not care even in rural America, since I live in rural America, then a veteran wouldn't, preferentially go there for care if there's not care available, whether it's codified or not. Yes or no, codifying access standards would make that determination one aspect of eligibility more transparent by codifying. Would it make it more transparent for veterans?
I think that's a complicated answer, Chairwoman Miller Meeks. I don't think it's a universal yes or no answer.
Okay, I'll accept that. I think that that's probably a reflection of reality, but would we in general agree that more transparency for veterans for their options would be desirable?
Yes, I will agree that more transparency is desired and desirable.
Thank you. Dr. Scavella, as several witnesses pointedly testified during our substance use disorder treatment oversight hearing, VA's determination that inpatient residential rehabilitation programs do not fall under the mission standards has resulted in delays and significant impact in providing access to veterans desperately seeking care. Some of the stories we heard were in fact heart-wrenching, and we also know members of our committee have also experienced delays through getting care at the VA. In your testimony, you state that the VA generally supports establishing a wait time standard of 10 or fewer days, but not codifying. Can you explain that, please?
Yes, thank you for the question, Chairwoman Miller Meeks. We obviously understand that when our veterans need to come in for a residential treatment program, we want to make sure that they have access. And so we are looking at those, at our current ability to meet the needs of our veterans, looking at trends from our veterans across this nation to ensure that we understand what are the bottlenecks, what is slowing it down. We do have a platform of different forms of care that we can provide to include telehealth, and in highly rural areas where there's not broadband access, telephone care is still possible as well. So we are looking at all of those things, but we don't want to lose the flexibilities in identifying how we provide this care to our veterans, realizing that we are committed to the same goal with getting them in as soon as possible for the care they need.
So, but as you've already stated, they're not required to receive care even in the community. So I think for me, the standard is veterans getting care when they need it, especially when it comes to mental health and substance use disorder treatment. Dr. Scavella, your testimony indicates, I'm going to ask you about H.R. 1182 in the short time I have left, Veterans Serving Veterans Act of 2023. Your testimony indicates that the VA already has a transitioning service member database in use. Is that database fully searchable? And if so, how do veterans and potential VA employees access this database?
Thank you very much for that question, Chairwoman Miller Meeks. We do have a number of resources. The one I believe you were referring to that's in my written testimony is the VA DoD Identity Repository, which does allow us to all 100% of all service members enter their information into that platform. So we're able to use that information to search and to match people to for employment. We also have social media outreach, as well as the VA Careers at va.gov website to invite our service members to put their information there, as well as many other platforms. So we do have a robust and diverse set of recruitment tools, and we're using those. But the one that is 100% utilized is the VA DoD Identity Repository.
I apologize, since my time is finished, if you could in writing submit to the subcommittee how veterans can access and the options that you just mentioned for VA employees and service members to access the database. That would be appreciated. Thank you. I now recognize Ranking Member Brownlee for any questions she might have. Thank you, Ranking Member Brownlee. You now have 5 minutes.
Thank you. Thank you, Madam Chair. So, as I said in my opening comments, I really do believe that we need to figure out what are the right standards for residential treatment, and that piece of the bill after our hearing, I think, is really important. I'm wondering, from the VA perspective, what you think the drive time should be for for using community care for residential treatment. You stated that a 30-minute drive is really not, drive time is not really appropriate, but what do you think is appropriate?
So thank you. I will turn that question over to my colleague, Dr. Hausman, for a response.
Thank you, Ranking Member Brownlee. Thank you, Ranking Member Brownlee, for the question. So our experience is that residential treatment facilities are just not available in every community. And in fact, veterans that have accessed these services in the community drive on average about 190 miles to do so. So we don't have an exact suggestion for drive time standard, but we think 30 minutes is far too short, just given the reality of that these facilities are not located in every community. In fact, not in most communities.
So, have you looked at commercial insurers, TRICARE, or Medicare or Medicaid plans to see if they have geographic network adequacy standards for this residential treatment care?
I will have to take that as a follow-up for the record. I expect that work has been done through our external networks team within IVC, and I will follow up with them and get that back.
Is that something that you would look at in terms of making recommendations for what the drive time would be?
Absolutely.
Okay. So, I don't want to pick on this bill because I really do believe the residential treatment piece is important. But as I said in my opening comments, I agree with some of the VA's concerns with regards to access standards, and I really believe that the trajectory on cost and community care is going in, an absolute upward direction. And I think if we just open up the access standards to for anybody to just say this is what I want is to go to community care, that trajectory is only going to increase and probably increase pretty substantially. So, do you have I know I mentioned that the CBO hasn't scored it, but based on our experiences, do you have any sense of what the costs might be?
We do not have a cost estimate worked out yet, but as was informed in the testimony, approximately 38% of VA care is now purchased in the community. That trend has been increasing significantly in recent years, and it's significant cost. So we'll take a specific cost estimate for this as a follow-up for the record, please.
So, so to what extent is VA currently able to inform veterans of their expected wait times for community care at the time they are deciding whether to opt for VA or community care?
Thank you for the question. I would say that is an important limitation that we have at present. Generally speaking, we are able to process a request for care, a referral, by first making sure that that request is clinically appropriate. From there, we determine veterans' eligibility for community care, and often they're asked to make a decision about whether they want to stay within VA or go to the community without being told the community wait time, what to expect, or where the community provider is located. That information is generally subsequently communicated at the point of community care scheduling. So I think it is a limitation right now that we're working to resolve, but we are asking veterans to make a decision on where to get their care with incomplete information a lot of the time at present.
Thank you. I yield back, Mr. Chairman.
I practice at a medical center where literally there's a VA center not a mile away. They don't have admitting privileges at our institution, so I will tell you it's in very close proximity. 1 in 7 of my constituents are veterans, so it is a big deal for us in Eastern North Carolina. Thank you again all for coming. I've been made more aware, really, of the number of increasing incidences where VA has not been in compliance with the Mission Act requirements and not made aware of their eligibility for community care. I'm original co-sponsor of Dr. Miller Meek's bill, and I believe this will correct and codify the current community care access standards. I'd like to dive down on this because when I was in private practice, we had an increasing issue with community care. As I said, there are a lot of veterans in my community, and we were always happy to see them. However, we were always happy to see them, but we were always not happy to never be paid by the VA. So I'd like to dive down on that in the few minutes I have, because in our community, we have a lot of talented surgeons, and for our guys, I live in a medical center which is halfway between Raleigh, we're in Durham, where our other main medical center is, hospital, where most folks get referred. So I'm halfway between Durham and the coast. And so we have veterans that come 2 hours north, 2 hours south, and sometimes 5 hours east just to come to Greenville, where I am, much less go on another 2 hours, 2.5 hours to Durham. And so being admitted to Durham from 5, 6, 7, 8 hours away is just not a good thing for our veterans. So I'd like to find out a little bit more about what your percentage is for actually paying providers who deliver the care, and your what your backlog is, because I will tell you guys, I hear from many folks who are trying to run practices. They want to see veterans patients, but you can't see them for free. So I'd like to know about the process we have of actually paying our providers. Okay, who can best speak to that?
Thank you for the question, sir. I can answer that one. And you are absolutely right. This is a very critical issue, and if we don't get this right, veterans are often stuck
Caught in the middle.
Yeah, caught in the middle, getting bills in the mail, which could be very stressful and have an impact to their health. So we appreciate the importance of this. The data you're asking for is gettable, and I will take that as a follow-up for the record. I will say directionally, this is something we have been following very closely, and we're doing better.
What does doing better mean? I'm sorry, I'm a surgeon, I'm kind of dumb.
I'll need to get that for you, sir, but I know we're in, I don't want to give you incorrect information, so I will take that as an action for the record if you would permit me, but.
Permit me, but you should have that on the top of your head, because that's an exceedingly important statistic for caring for our veterans.
Yep, absolutely, completely agree. I want to say we're in the high 90% range. I'll get you the specific information.
Because I want to know this. I want to know, one, are claims being paid? 2, how many denials, how many claims? In other words, how many times do I have to have somebody in my practice call back, go back to the VA It's worse sometimes than banished to say some of the insurance companies that love to deny, deny, deny. Our purpose in providing care to veterans is to provide care to those who've sacrificed for our country. And for us not to be able to do that, you have to pay staff, you have to pay the light bill, you have to pay the other things. So at some point, it gets to be where we give out charity care every day. And it can't be charity care to our veterans. They don't want charity. They deserve to be have their providers cared for so that they can do this. This is a major item, and I would submit 90% is not near close from what I hear from our practice manager and from other practice managers in this vicinity. So that's my main item. I'm not going to beat on anything else, but this is a big deal. We need to get the people who care for our veterans outside of the VA paid, period. So thank you. I'll recognize Ms. Buzinski for 5 minutes.
Thank you, Mr. Chairman, and thank you, Ranking Member Brownlee. Thank you to the panelists for being here. My first question, Dr. Scavella, regarding H.R. 3520, the Veterans Health Care Improvement Act. Can you elaborate a little bit more on the VA's opposition to this provision in the bill, Section 2 specifically, that would bar the VA from factoring in the availability of telehealth appointments when making community care eligibility determinations?
So thank you for that question. I will also refer that to Dr. Hausman.
Okay.
Thank you for the question, ma'am. VA is proud of where we have come with telehealth. Last year we did over 9 million appointments. We have between an 88 and 90% trust and satisfaction rate with veterans for telehealth appointments. Telehealth has become an important modality for healthcare delivery. And as the Secretary mentioned back last fall in September, VA is looking at the possibility of incorporating available clinically appropriate telehealth appointments into access standards. The way we would do this would be through a rulemaking process, which would, of course, allow for visibility and time for public comment. An additional important point as we think about telehealth and veterans is we want to preserve veterans' ability to choose their modality of care. In other words, if a veteran is not comfortable with telehealth, does not want telehealth, we don't want to force that modality. So that's another component to how we're thinking about this.
Thank you for that. And so I just wanted to elaborate on the district that I represent. I too come from a more rural part of the country. I represent central and southern Illinois. And I have heard concerns around accessing care. For too many veterans often have to travel long distances to access essential health care. So I certainly understand the need to get our veterans care as soon as possible, including using community care when necessary. But I'm concerned that this provision in H.R. 3520 would prevent our rural veterans from having that telehealth option that you just spoke about. According to the American Hospital Association report, there were over 130 rural hospital closures between 2010 and 2021, and the pandemic has left hundreds of other healthcare facilities throughout the country at risk of closure. I support community care when needed, but I'm worried potential closures of these hospitals and facilities may end up leading veterans to having to wait just as long or have to travel just as far to get to community care. And taking away telehealth options may only really exacerbate that issue. That is my real core concern with this. So if I might follow up with you, Dr. Hausman, on another question. Do you believe this provision would hurt our rural veterans and or similarly severely limit the access to telehealth services and health care just in general?
Thank you for the question. I will say that we want to do everything we can to bring options to veterans, including telehealth, which, as I mentioned, is becoming an increasingly important modality for care. And as we're seeing ongoing pressure on rural markets and the loss of providers and potentially the loss of hospitals, we do believe that telehealth becomes that much more important as a way to fill that gap. So anything that would limit our ability to offer options to veterans, including telehealth, we would not be in favor of.
Do you see this provision, though, as being something that would do potentially that?
I think it's a complicated question. I think, with this provision in place, ideally we would still offer the VA telehealth option along with the community option. I think in practice, in reality, once we determine a veteran is community care eligible, oftentimes we schedule in the community without taking a hard look at what VA resources are available. Now that's a process that is on us to fix, and we're working on it, but I think that's the challenge there.
Okay, thank you. I yield back my time.
Thank you, Representative Buzinski. The chair now recognizes Mr. Landsman for 5 minutes.
Thank you, Madam Chair. Thank you all for being here and the work that you all do on behalf of veterans. The concern I have with the bill has to do with diverting resources from best practice care that we know veterans get from the VA. I'm from Cincinnati, Southwest Ohio. We have a phenomenal facility in Cincinnati, and we know that the care is top-notch. We don't have standards for these community options, so we don't know. It's questionable what kind of care our veterans are going to get. It's not questionable what kind of care they're going to get from the VA. So the idea that we would divert resources is challenging. Obviously, if there was, if this had been done in a bipartisan way, which I think most things ought to be done, if not everything should be done in a bipartisan way, because I think we could have gotten, and maybe we will ultimately get to a better place in terms of ensuring that people have options, but there are the highest standards, that we're not undermining VA benefits, resources, care. You have cited concerns that the VA will no longer be the go-to caregiver for many veterans if this were to pass. In your view, what do you think that looks like, and why is it so important to keep care within the VA?
Thank you, sir, for that question. And I do appreciate the statements you made about the quality of care that's provided and within VA. We're very proud of that. We're very proud of our recent HCAHPS results with better veteran satisfaction across 10 categories compared to the community, as well as numerous studies that have come out over the last 5 or so years that have shown VA is as good as and often better than the community care alternative. There are also challenges with community care. We had a hearing, I think it was a couple of weeks ago, where challenges with care coordination have been discussed. So, these are things, again, on us to fix. But as things stand today, that is the reality. We don't get 100% of medical information back. We need to fix that. That results in challenges with care coordination. And we know sometimes when veterans get their care in the community, it is likely not as high quality, and certainly veteran-centered care is what we can provide. We're passionate about providing health care to veterans. That's why we do what we do. That's what motivates us, and it's really inspiring to see that we're doing a great job with veteran perception with our hospitals, as well as the quality that's been proven out in several studies.
Thank you. In your opinion, what would be, because there is an argument, right, that oftentimes in certain places, or just based on what a veteran may need, that a community provider may be closer, better positioned to provide that support. I don't want it to be too leading, but my sense is that if there were the same level of standards, and that there were certain pieces of the agreement that it could be, in fact, beneficial, but there would have to be a real, had to be real structure to those partnerships. Do you have any an opinion about that, or what that could look like?
Yes, sir. Completely agree with that assessment. I will share that those items are being worked on as we're looking at our next generation for our clinical, or for our community care network. specifically, how do we measure quality? How do we then communicate which providers are of highest quality to veterans that are community care eligible? How do we better facilitate the bidirectional exchange of medical information, thereby enhancing care coordination and clinical outcomes? So all of these are very much in front of us and are being actively worked on as we're thinking about the next contract for our community care network.
Thank you so much, and I yield back.
Thank you very much, Representative Landman. No one has challenged the quality of care provided at the VA, but you can have the best quality of care, but if you can't access it and you commit suicide, you've had no care at all. So I thank all of our witnesses for giving testimony and joining us today. On behalf of the subcommittee, thank you so much. You are now excused, and we'll wait a moment as the third panel comes to the witness table. Thank you. Welcome, everyone, and thank you for your participation today. On our third panel, we have Mr. John Retzer, Assistant National Legislative Director for Disabled American Veterans, Ms. Tiffany Ellett, Director, Veterans Affairs and Rehabilitation Division for the American Legion, and Mr. Cole Lyle, Executive Director of Mission Roll Call, a program of America's Warrior Partnership. Mr. Retzer, you are now recognized for 5 minutes.
Chairwoman Miller Meeks, Ranking Member Brownlee, and members of the subcommittee, thank you for inviting DAV to testify at this legislative hearing. I will focus my remarks on the bills under consideration today that most affect service-disabled veterans. DAV supports H.R. 1182, the Veterans Serving Veterans Act, which would require the VA to maintain a database of vacant positions with corresponding military occupational specialties or skills to recruit qualified members to fill the position prior to discharge. VA must aggressively look at all means to successfully recruit highly trained, dedicated professionals to ensure and deliver sustainable, high-quality health care. We support H.R. 1278, the DRIVE Act, which would require the VA to ensure beneficiary travel reimbursement rate is at least equal to the GSA reimbursement rate of federal employees. This will ensure VA's travel reimbursement rates keeps up with the cost of inflation and properly accounts for fluctuations in gas prices. Veterans should not have to choose between getting care they earned and deserve and the rising cost of travel to access their needed care. 17 veterans take their own lives every day, twice the rate of non-veteran peers. We must work collectively until we get the number down to 0. Losing one service member or veteran to suicide is one too many. DAV supports H.R. 1639, the VA's Zero Suicide Demonstration Project Act. This bipartisan legislation would bolster clinical training and resources to test the effectiveness of the pilot program and improve the quality of the mental health care services that our hero veterans deserve. We support H.R. 1774, the VA Emergency Transportation Act, which would provide veterans reimbursement for the cost of emergency medical transportation, regardless of provider or medical facilities. DAV supports H.R. 1815, the Expanding Veterans Option for Long-Term Care, which would require the VA to carry out a program to determine the effectiveness of providing assisted living services to eligible veterans who are currently receiving nursing home care through the department to meet the increasing demand of long-term care. We support H.R. 2768, the private first-class Joseph P. Dwyer Peer Support Program, which would require the VA to establish an advisory committee to create standards for grant recipients to carry out a program to hire veterans to serve as peer specialists to provide veterans non-clinical mental health support. Peer specialists would provide unique support to veterans by sharing their personal experiences to navigate veterans' recovery journey. Home improvements and structural alterations rates have not changed since Congress last adjusted them in 2010. However, the cost of home modifications and labor have risen over 40%. DAV supports H.R. 2818, the Autonomy for Disabled Veterans Act. This bipartisan legislation would increase the amount of funding for VA grants for disabled veterans to make necessary modifications to their homes to fit their needs and would adjust the amount to account for inflation. We support H.R. 3581, the COPE Act, which would authorize the VA to provide grants to organizations that focus on increasing mental health care services and resources for caregivers. Finally, H.R. 3520, the Veterans Care Improvement Act. While DAV strongly supported the Mission Act and creation of the Veterans Community Care Program, we have questions and concerns about some sections of this legislation. We certainly agree that whenever and wherever VA is unable to provide timely, accessible, high-quality care to enrolled veterans, VA must provide other care treatment options. We believe it is critical to strengthen and sustain the VA healthcare system that millions of veterans choose and rely on for all or most of their health care. As studies continue to show, the care provided by VA is equal to or better than private care sector on average. While we support the intention of improving the VA community care program, we believe it is essential that VA remain the primary provider and coordinator for veterans' medical care. Therefore, we ask the subcommittee to consider the concerns we outlined in our written statement and that we would be pleased to work with you to address them. Chairwoman Miller Meeks, this concludes my statement, and I'm happy to address questions you or members of the subcommittee may have.
Thank you, Mr. Retzker. Ms. Ellett, you are now recognized for 5 minutes.
Thank you. In April of 2020, my friend Greg, a government employee on the verge of retiring, died by suicide via firearm. Exactly 1 year later, my friend Carl, a retired Army veteran, and county sheriff suffering from PTSD, died by means of self-medication. 5 months later, a boy, like a second son to me, named Cole, a 21-year-old college senior and son of a Marine veteran, died by suicide via firearm. This past February, my friend Bruce, an Army veteran who served in a special unit in Panama, died by suicide via hanging. Mental health and suicide doesn't just affect one community in one way. This is a complex problem that needs a multifaceted solution. We as a society need to do better. Chairwoman Miller Meeks, Ranking Member Brownlee, and distinguished members of the subcommittee, on behalf of our National Commander Vincent J. Jim Troyola and our more than 1.6 million dues-paying members, we thank you for inviting the American Legion to testify today. According to the Substance Abuse and Mental Health Services Administration, in 2021, an estimated 12.3 million adults in the U.S. seriously considered suicide. 3.5 million planned an attempt and 1.7 million attempted. Veterans Health Administration is the largest integrated healthcare network in the United States. If any organization has the ability to pull together the means to create a multifaceted solution to the mental health epidemic plaguing the United States and its veterans population, it's VA. In 2021, the American Legion started its Be the One movement to destigmatize and encourage the discussion of mental health, suicide, and seeking help. This movement, in combination with our Buddy Check program created in 2019 and adopted by VA through 2023 legislation, are examples of the American Legion's constant, vigorous support of peer-to-peer solutions for veterans' mental health complexities. The American Legion strongly supports the VA Zero Suicide Initiative pilot and the PFC Joseph P. Dwyer peer support programs. Mental health struggles or feelings of isolation can be exacerbated during transition from service through a veteran's perceived loss of identity or mission. One of the solutions for this empty space is to immediately provide a mission to the veteran. This is just one of the reasons we support the Veterans Serving Veterans Act of 2023. which assists in building a direct path for exiting service members to feed into the VA recruitment pool. Another reason we support this act is the direction to train and certify corpsmen or medics to become intermediate care technicians, ICTs, augmenting the VA medical workforce. That being said, we would like to see the Department of Homeland Security added in this legislation so that Coast Guard Health Services technicians may be included in the recruitment database. We think the VA ICT program is one that with increased use could not only assist in amplifying personnel for our veterans, but could also provide much needed transition assistance to those exiting the service by giving them a mission to move directly into. Separately, I would like to address legislation being considered to expand care for our veterans through improving long-term care, home services and living conditions, and community care. The American Legion believes that veterans and their families are best served when their long-term care needs are promptly met while also honoring self-autonomy and giving them the choice to remain within their local communities. We support the introduced legislation that not only calls for an increase in funding to support housing improvements for disabled veterans so that they may retain self-autonomy in the comfort of their own home, but also that which calls for codifying community care access standards to ensure veterans will receive timely, quality health care. A final note to mention the importance of our caregivers and their mental health. Often the caregivers of veterans, be they spouses, siblings, or even children, carry a burden that many of us don't see. They do such a good job of holding up the veteran that no one sees the cracks in the foundation. As a disabled veteran, the spouse of a disabled veteran, and an advocate for our veterans and their families, I've witnessed the demons that lay in wait in the dark for each of us. The American Legion calls on Congress to pass legislation such as those discussed today to assist in evolving care and support for our nation's veterans and their families. I conclude by thanking Chairwoman Miller Meeks, Ranking Member Brownlee, and this subcommittee for your incredible leadership and for always putting veterans at the forefront of your mission. It's my privilege to represent the American Legion before the subcommittee today, and I look forward to answering any questions you may have.
Thank you, Ms. Ellett, and on behalf of the subcommittee, we're sorry for the loss of your fellow service members and friends. Mr. Lyle, you're now recognized for 5 minutes.
Thank you. Chairwoman Miller Meeks, Ranking Member Brownlee, and members of the subcommittee. On behalf of Mission Roll Call and the roughly 1.4 million veterans and supporters in our digital advocacy network, thank you for the opportunity to provide their feedback through our remarks on pending legislation. While all the proposed bills are worthy of discussion and will have impacts on the veteran community, I will focus the bulk of my time on the Chairwoman's bill, H.R. 3520. Mission Roll Call strongly supports this legislation as a necessity to ensure veterans receive timely access to quality care. The Mission Act of 2018 streamlined a congealed process that existed via the Choice Act, and Congress's intent with Mission was clear. The VA must increase access to private doctors when the VHA cannot provide care in a reasonable time, distance, or if it was in the best medical interest of the veteran. In 2021, reports surfaced that VA administrators were overruling decisions by VA doctors and patients to keep veterans in the system, in some cases cutting off care entirely. The article simply confirmed what many VSOs providing care coordination and casework already knew, that to protect VA's parochial interest in some areas of the country, it was unnecessarily difficult for veterans to access care in the community when it was in their best medical interest. In 2022, 4 years after Mission was passed, Secretary McDonough testified community care now accounts for 1/3 of VA's healthcare budget. As a result, the Secretary said the VA would look at changing access standards and use telehealth availability to determine wait times. Using the broad capabilities we have available, Mission Roll Call conducted a poll question on the issue, and with over 6,300 veteran responses across America, 81% said Congress should codify the access standards. Further, Mission Roll Call asked questions on the more general veteran experience accessing community care. With an average of 6,200 responses across 7 unique polls, 60% of veterans said their providers don't make them aware of this option after a delay in care. 37% said they had experienced a delay or postponement of any healthcare appointment at a VA facility. 71% said they were not referred to the community after a delay in mental health or other specialty care at a VA facility. 22% experienced problems scheduling the care once referred. 14% said their providers referred them to the community, but the referral was later denied by the VA upon review. And lastly, 21% said their providers scheduled them a telehealth visit to access care when they preferred in-person visits. This clearly indicates an issue simmering beneath the surface. But the problem can be found in more than just statistics. During Mission Roll Call's geographically diverse fact-finding tour last year, meeting with over 5,000 veterans individually in California, Texas, Florida, Alaska, Arizona, Idaho, Montana, and elsewhere, these problems were borne out in personal testimonies of countless veterans. While those with good experiences at VA mitigated their healthcare issues and went on living their lives productively, those with negative experiences accessing healthcare in VA or being referred to the community either gave up trying or were not shy telling other veterans to stay away from VA. The issues ranged from primary care appointments for things like allergies to significant mental health issues. A few stark responses from veterans said they had peers whose mental health spiraled after being frustratingly unable to access mental health care. To the best of my knowledge, none of these examples ended in suicide. But with less than 50% of the US Census Bureau's estimated 17.4 million veterans in America enrolled in VA, and even less using it on a regular basis, making it harder to access health care when needed is counterproductive to the VA's interest, regardless of where the care takes place. As the VA is the largest healthcare system in the country and the second largest federal agency behind DoD, it's understandable why officials sometimes make big decisions with respect to workforce recruitment and retention. However, Congress must ensure the agency keeps the veteran, not agency interests, as their North Star, and not defer or be unduly influenced by workforce considerations when those decisions could negatively impact the individual veteran's ability to seek health care. After all, the VA's core mission is to care for those who have borne the battle. Mission Roll Call has also supported a similar bill in the Senate, the Veterans Health Act. We hope the House and Senate pass both bills in a bipartisan manner to pass this urgently needed legislation to protect veteran access to timely health care, whether that is in a VA facility or not. Madam Chair, this concludes my testimony. Mission Roll Call would like to thank you and Ranking Member Brownlee for the opportunity to testify on these important issues, and I'm prepared to take any questions you or other subcommittee members may have.
Thank you, Mr. Lyle, and thanks to all of our witnesses today and for their thoughtful inputs. I now recognize myself for 5 minutes. Mr. Lyle, and you may have answered this, but you listed 7 unique polls that Mission Roll Call conducted on veterans accessing community care. And interestingly enough, they mirror what I experience when I talk with veterans within my district, and I'm a fellow veteran. I'm married to a fellow veteran. You also state in your testimony, the data clearly indicates that there is a problem simmering under the surface on this issue, referring to community care. And you may have addressed this, but could you again briefly expand on this problem?
Thank you for the question, Madam Chair. I think if we look at community care in the program since 2018, obviously it has expanded dramatically. So by and large, the program is working well, but I think people that work with veterans on the ground, talk to veterans, and get their learned experience can tell you that they or someone they know has experienced some sort of issue accessing care in the community. I myself use the VA full-time for my care, for everything, and I've experienced, the vast majority of my care has been good, has been excellent, but I still have experienced the occasional problem accessing community care.
Ms. Ellett, the quality of community care is often debated in Congress. In your opinion, can you provide an example of a veteran and how community care is safe, effective, and timely for veterans seeking to receive care in the community?
Thank you. Thank you, Madam Chair. I think that, there's a couple of things that come to mind that didn't have really good outcomes because community care, there are good and there are bads in community care as well, just as well as VA. I know that I have to drive an hour and a half to Richmond to my medical center for some of my appointments, and the closest CBOC that I have is 45 minutes away. So I was medically discharged from the Army for my back issues. I do drive an hour and a half to work every day because I love it, but it takes a toll. So driving for another 45 minutes to a chiropractor isn't very helpful for me. So I do use my community care in that sense, and it's extremely helpful. It's only 10 minutes away. So they they seem to have a positive relationship between VA and the community care there. So that's kind of a success story, although we are aware that that's not always the case.
I think I found that in both instances in community care and in VA care, and having been a provider in community care, I had excellent ratings as well. Mr. Retzer, in your statement, you mentioned the DAV supports a searchable database consisting of existing military medical personnel for the purposes of recruitment. How confident are you in the VA's ability to, one, protect this information and maintain privacy, while also being able to connect service members to potential opportunities within the VA?
Thank you for that question. I think as far as the confidence with the electronic databases that we're challenged right now with the VA, I think we can take some lead with the Department of Defense, being that this is going to be military occupational specialties and skills that are going to be listed in the record with individuals' information that have served or are serving. I think lessons can be learned as we navigate to make those databases. So I think some of the confidence levels of maintaining privacy is there because they do that with our veteran care information that we have as ourselves as veterans. But I think they need to be a little bit more mindful of the fact that we are literally talking about service members putting their databases into the system. So I think as we navigate it, they can continue to learn from lessons learned in their developments.
Ms. Ellett, as you know, the veteran population is aging, with more senior veterans requiring long-term care. You note the importance of providing veterans choice in care. Do you agree that H.R. 1815 will provide veterans with timely care to their long-term care needs while also remaining cost-effective?
Yes, we support it, and we think that it'll be a good supplement, we're really just looking for something to assist VA in taking care of the expanding, aging network of veterans.
Thank you. I yield back. Ranking Member Brownlee, you're now recognized for 5 minutes.
Thank you, Madam Chair. I wanted to ask a question, really, of all three of you and get individual answers from you. So if we codified all of the access standards, including I just want to get community care, what do you believe that would be any impact on VA's direct care system at all?
Thank you for that question. Where DAV is concerned with regards to Section 2 of this bill is the codifying is that we feel concerns with the limitation and flexibility that the VA would have to ensure that we as veterans who are getting the health care at the VA would have that option of care for our individual needs. So one of the things that we see is that the Mission Act already provides the guidance for the VA. We just need to ensure that VA is held accountable to the access standards and the quality of standards. That's the most important thing, is the quality of standards. We can have access and timely scheduling, but we have to make sure that we have that quality care provided to each individual veteran. And the other thing that we see is that, if we limit that access for the VA, individual care out in the community, one of the things that they do not have are the same access standards or the quality standards. So that is one thing that we do not have at this time to be able to measure what is really happening out there that would be beneficial for our safety and quality of our care. Let alone, I think there's a second component there for us to look at, is that when we look at community care, they don't have the wraparound services that veterans need. And one of the things that we veterans deserve to have are the core values that VA is built on. And if I can read them out for you, the strengths that they have is system-wide clinical expertise regarding service-connected conditions and disorders. And that's one of the things that we veterans walk into a community care and VA care system, is that we have multiple issues. So as many of us suffer from musculoskeletal conditions, we also suffer from mental health. And even when we are trying to get those resources, we may be seen for medical for the mental health, but it's exacerbated because of our chronic pains. So the wraparound services are very important. That direct care handoff, that warm handoff to different departments is important.
Thank you. Ms. Hallett?
Thank you for that question, Ranking Member Brownlee. We never want community care to replace VA. I don't think that it'll be detrimental. I think that it will expand or open doors to possibly veterans who aren't willing to seek VA care So asking them, giving them at least the option. Now, I've experienced good VA care. I've also spoken to many veterans who've experienced poor VA care. And some of them will choose not to get care, and that's the last thing that anybody wants. So it's really just giving them that option, just that window of opportunity to get that assistance. But we don't think that it's going to be, kind of privatize VA. We don't believe that that's what's going to happen. One of the issues is you still have communities out there like the LGBTQ community who has a hard time going in and trusting VA facilities and VA staff. So just even opening up that branch to say, hey, if you come in and talk to VA, you get the option if you want to come here or go to community care. That might do a lot to build a bridge for that community or other underrepresented communities of veterans in order to build that trust back up.
Thank you. And Mr. Lyle?
Thank you, Ranking Member Brownlee. I think my response would be if the veteran is getting the care they need when they need it, then that's not detrimental to anybody, including the VA, whose core mission is to take care of the individual veteran. And if you give them a choice between VA care and community providers, if all the studies that VA touts about veterans preferring care at VA facilities and that VA care is demonstrably better, then why have we seen the explosion we've seen in the last 4 years? That's a question that the VA has got to answer. Why are they meeting so many of the access standards requirements currently? Let's look at the VA experience and see how we can improve that if the goal is to get the veteran the best care possible when they need it.
Very good. I mean, I agree really with all of your answers and responses. I just am, still sort of maintain the concern that the trajectory of community health care, is continuing to rise, and we don't have an endless bank account in some sense. And I don't want to, put a bank account against the care of our veterans by any stretch of the imagination, but I think the data shows that the veterans prefer health care inside the VA, assuming it's good health care and they can have access to it and it's quality care. And I just worry about losing resources to continue to continually improve upon the VA healthcare services itself. It's I don't know where the sweet spot is and where it's a delicate balance, and I'm not sure where it is, but and we've got to figure that out. But I do agree that the VA has to answer for why the demand on community care continues to go up. Am I over time already? Oh, I apologize. I yield back.
Thank you, Ms. Brownlee. The chair now recognizes Mr. Landsman for 5 minutes.
Thank you, Madam Chair. I have just a question about Congresswoman Lee couldn't be here, but she, in her bill, she calls for this VA Zero Suicide Demonstration Project, which creates a program that implements the curriculum of the Zero Suicide Institute of the Education Development Center. And I just wanted to know if you guys were familiar with the curriculum, if thoughts on the bill or the need for that kind of support within the VA. And any of you can answer that. Just wanted to get your perspective.
Thank you, sir, for the question. I think when we look at suicide, veteran suicide broadly, I support any effort to improve training and care within VA facilities to try to expand outreach and prevention. But again, with less than 50% of veterans enrolled in VA care, VA has to do more. I think less than 1/10% of their annual budget goes to suicide prevention initiatives, and that includes Fox grants. So it would be my opinion that a more far-reaching way to fight this problem would be to expand Fox grants for community providers that have touch points with veterans that the VA will just frankly never have.
Yeah, thank you. And one of the things that we talked about with the administration were the partnerships with these community providers and getting to a point where there are agreements around sharing medical records, around the standard of care, and being able to increase those grants along with those partnerships. But without those partnerships, we could be sending folks into pretty questionable situations. Do you comment on that? I mean, do you agree with that? Do you
Well, I think
feel differently?
I think anytime that Congress mandates the VA enter partnerships with community providers, usually there's some prescription of rules guaranteeing certain ethical and programmatic standards that these programs have to adhere to. And in many cases, with the Fox grants, the requirement to submit programmatic data back to VA requires a full-time employee. It's not a small job. So I would just say that I don't think under current conditions for these types of programs that would be a huge issue.
Just and also a question for any of you or all of you. One of the issues that we have, so I'm from Cincinnati, Southwest Ohio, and we have a VA, a great VA. One big issue we have as I talk to veterans is those who are struggling, really struggling, obviously are isolated, and being able to connect with somebody and is the biggest issue. So whether they get the care at the VA or somewhere else, it's getting connected. And so one of the issues or things I've been trying to understand better is what we do well in terms of outreach, where we could do outreach better. So let's just put aside the question of whether you get the care at the VA or a community provider. I still think there's this big question, I could be wrong, this big question as to whether or not we're really going out of our way, like going to meet veterans where they are, and if so, what does that look like? What is best practice outreach so that we can get folks, start to build those relationships, and then get them the care that they need?
I'll share with my experience as almost 20 years of advocacy with the DAV, advocating for our veterans' benefits and health care. DAV prides themselves on providing information seminars, where we actually do these information seminars talking about VA benefits and navigating the healthcare system, and partnering with the VA for the homeless programs and also with employment opportunities. Is one of these things that we use as peer specialists. So peer specialist concept with the DAV is not new, because our National Service Officer, wartime service injured and ill veterans, who serve veterans to help veterans navigate VA system and to build that confidence. I think that's one of the things that we as a panel has already expressed our experiences with our service and what we do as advocates to be able to build that confidence and build the relationships with the VA and our veteran community to have more reassurance that they're not alone in their journey, as I had stated earlier.
Excuse me, just a quick comment.
My time is up. I apologize,
okay.
But we'll circle back afterwards. I apologize, Madam
right.
Chair.
Thank you.
But I yield back. Sorry.
Thank you. I was waiting for you to yield back. Thank you very much. Ranking Member Brownlee, would you like to make any closing remarks?
Not really. I appreciate you having this hearing and bringing these bills forward. And I look forward to the next steps in terms of markup and moving the bills along.
Well, I just want to thank my colleagues on both sides of the aisle, the department, our VSOs, members who presented to us today in addressing the issues that we discussed. I appreciate your feedback, and we'll look into that. But as both a veteran, a doctor, and a former nurse married to a veteran who is a nurse, I think what's most important is that we take into consideration those veterans who are not receiving care in a timely fashion. It doesn't matter if you have the best quality care in the world if you cannot access that care by not getting an appointment. One of the first things that I did as a new member of Congress when I was elected in 2020 and 2021 was to work in a bipartisan fashion to pass a bill because a service member from 60 miles away went to the VA in Iowa City for mental health care, was denied care, and 5 hours later committed suicide. It was the first bill I was on and was signed by President Biden. That's why this is an important issue. Codifying community care, and especially access to care in the community for substance use disorder or severe mental health disorder, does not mandate that care has to be provided in the community. Codifying only means that the VA understands that it is their duty and their mission to make sure that care is accessed. No one wants to divert from best practices, and there are parameters that we can put in place. I'm a staunch supporter of telehealth and had bills on telehealth immediately when I came into Congress to make the waiver permanent that had occurred. And care coordination is at the behest of the VA. And yes, we did hear about care coordination. And for those, I was a nurse at Walter Reed taking care of spinal cord injury patients, flipped a lot of strikers in my time, suctioned a lot of patients that were managing on ventilators. I know the care coordination is important, but that is at the behest of the VA to improve their practices. So I think for all of us here on the committee, what we're most concerned about is that veterans have access to care, and of course, we want it to be high-quality care, and we want it to be timely. So I look forward to working with all of you. The complete written statements of today's witnesses will be entered into the hearing record. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and to include extraneous material. Hearing no objections, so ordered. I thank the members and the witnesses for their attendance and participation today. This hearing is now adjourned.